Hi, everyone. I am Markeisha Woodson. I'm with the Rural African American Health Coalition. I want to welcome and thank you for joining us this evening. This workshop that Dr. Wanda is doing for us is part of our Black History Month series focusing on health disparities in Black mothers, families, and babies and ways that we can improve health outcomes in our communities. Tonight we have with us Dr. Wanda Averhart. She is a double board certified physician in general pediatrics and obesity medicine. She has developed her skills at patient care through her experiences working in a variety of outpatient settings from academic medicine to underserved healthcare to private practice to telehealth. Dr. Averhart is a well-rounded physician that excels in leadership, education, communication, and providing comprehensive, culturally competent patient care. Now caring for children and adults within three different practices, Dr. Averhart is improving care and health outcomes for everyone with the goal of building a more equitable healthcare system and world for us all. Today, she will be speaking with us about RSV and caring for Black babies. I will now turn it over to Dr. Averhart.
Well, thank you so much for that wonderful introduction. I want to thank the Aurora African American Health Coalition for inviting me to speak with everyone today. Today, we'll be talking about RSV, so I'm just going to share my slides. Hold on. All right. Can everybody see what I'm presenting?
Yes.
All right. So let's start off right here. Again, Dr. Wanda Averhart. I'm a general pediatrician and an obesity medicine specialist. Today we'll be talking about RSV and disparities in care for our African American babies. What is the leading cause of infant hospitalization? That is RSV, and that is one of the reasons we're talking about this today because it puts a lot of our babies in the hospital. So, what is RSV? RSV is short for Respiratory Syncytial Virus. We don't say it quite often, but that's the long name. I'll abbreviate it with RSV. It's a very common respiratory virus and is very hard to distinguish from what we would say is the common cold or COVID. It infects the nose, the throat, and the lungs. It is the most common cause of what we say is bronchiolitis. And so I'll talk a little bit about why the name is bronchiolitis. It's basically because of where the infection infects. It infects the lower parts of the lungs, and these lower parts carry oxygen in and out of the lungs, and that's what's called the bronchioles. And you'll see at the little baby, he has his bronchioles, tiny airways. And when those tubes get infected, you get a lot of inflammation in the airways where it's swollen and it gets clogged with mucus. And so that makes it harder to breathe and hard to get oxygen throughout your blood. So think about it as if you were trying to suck a smoothie out of a very small straw versus a large straw. So typically they'll give you a large straw because you can actually get something through. Imagine if your airways were swollen and your airways were now those small straws, you wouldn't get much through. So that's what happens with bronchiolitis. Again, it's a common respiratory virus, but it can be very severe in two extremes, those that are very young and those that are very old. And so that's why we talk a lot about it, specifically in those that are very young and happen to be premature. Symptoms include cough, runny nose, congestion, fever, wheezing, decreased appetite. Typically, these are what we see in babies. Now, RSV has a typical progression. The good thing about this illness is once you find it, you can usually tell the parents how it will progress so they can be aware. The first to third days are usually mild symptoms, runny nose, cough, some congestion, a mild fever, or even some cough. By day 3 to day 5, things tend to peak or be at its worst. And so that's when kids will have higher fevers. They'll have coughing with wheezing or even increased work of breathing. That can be kind of scary. So I'll show some videos about what that looks like. This day 3 to day 5 is usually when parents present to either the clinic or the hospital with their baby because they're having some distress. After that fifth day, about day 5 to 10, symptoms tend to improve, things get better, fever resolves, but sometimes that cough can linger for a few weeks or so. So that'll be the last thing to leave. So here's a video that kind of goes over some of the severe symptoms that can occur with respiratory syncytial virus or RSV. So take a listen to the video.
Hi, my name is Dr. Joanna Pargabalinki. I'm a pediatrician, neonatologist, and I'm also pregnant. So I'm thinking a lot about babies, and with cold and flu season coming, you're going to hear a lot about RSV. I want you to know the signs and symptoms that might mean you need to call your pediatrician or go to the emergency department if your baby has respiratory distress. Let's watch a video together. This baby is having a lot of trouble breathing. They're using extra muscles, so you can see them actually using the muscles underneath their diaphragm. And you can also see them with tracheal tugging, meaning they're using extra muscles up here too to breathe, and they're not moving much and their eyes are closed. That, and they start to turn blue. So when you see your baby working really hard to breathe, they can't do anything else and they're turning blue, that's a time again to call your pediatrician or go to your nearest emergency department.
So she just described a very sick baby. If you see something like this, it's typically the time to go to the emergency room, not just call your pediatrician. And so that was a schematic, a drawing about how a baby can look when they're severely infected with RSV. What I'm going to show you is an actual live baby that is suffering from RSV. I will warn you, it does look a little scary in the beginning with the coughing that the baby's having, but you'll notice that by the end, the baby tends to calm and things get better. So it looks scary, but the baby is okay.
Something like this for how long?
She just started a little bit last night and stopped. And
Okay.
then when she woke up this morning, it was just constant.
Constant coughing. All right. She running a fever at home? All right. No fever at home. She eating all right? Okay. She ever turn blue or have any episodes of stopping breathing?
No.
No. Anybody else in the family sick?
Her sister got a cold. I think that's where she got it from.
Okay. And is she in daycare at all? So we're going to do a pertussis test, and that's been ordered. So now we're, this is nebulized epinephrine, and we're doing, how much we're giving her?
2.5 ml.
Of the 1 to 1,000.
And
All right.
3 ml normal saline.
All right, so her coughing slowed down, and her, she seems to be breathing a little bit easier, still breathing very fast. Still has the abdominal breathing, but I don't see as much intercostal or subcostal retraction going on.
So with that baby, as you can see, that baby was in a lot of distress initially. It kind of clued into some of the things we talked about, which was the tugging right here by the trachea, some of the belly breathing, and then the constant coughing that the baby was having. You may have heard on the video that there were a lot of talking. There's additional tests that you do when you're suspecting RSV. And so that's what pertussis was. It's another test for another illness that can cause similar symptoms. And then they even talked about other medications that can be tried when a baby is in distress like that. You may have heard racemic epi, which is a medication that can be used not specifically for RSV, but in the clinical setting to kind of help support babies when they're going through that. And so that kind of clues into the support measures that are used. Overall, with RSV, there's no cure, but it has a typical progression, is what we discussed. Now, how do you get RSV? It is that season. So RSV has a seasonal pattern. Um, Typically, somebody has to be infected with it. They cough around you, sneeze around you, and the virus droplets get in your eyes, your nose, or your mouth. So that's their entry part into your body. There's also direct contact. If, say, for instance, you are sick and you kiss a baby in the face, or a child comes to you and they're sick and they kiss you, you can get RSV by that way as well. So I typically tell parents of new babies, do not allow anyone to kiss your baby. You should probably hold off for a little while, especially if you happen to be sick or anything. And then you touch a surface like a doorknob or a handle when it isn't clean, right? And then you touch your face without washing your hands. So those are the ways that you can contract RSV. So, talking about the seasonal pattern of RSV, this is a graph that kind of goes over a chart. I'm sorry, that goes over what peaks RSV has in different seasons per year. So, if you look at the solid blue line, that is the 2017 to 2018, it peaks in December or so. As you move on, 2018, 2019, it peaks around December, January, around that new year. And then 2019, 2020, it peaked around that same time. So that's a typical seasonal pattern we see for RSV. What happened specifically in 2020? We had the COVID lockdown. We had a lot of mask and staying at home. And so the 2020 to 2021 chart, I mean, 20, yes, 2020 to 2021, you will see it is completely flat. It doesn't even show any cases until June or so. And that is a direct correlation to the fact that everybody was in the home. Everybody was definitely social distancing and wearing masks. And then when you get to 2021, 2022, you see a little bit of a peak in August, but it really doesn't show that typical pattern. It's not until 2022, 2023 that you get a more typical peak around November or so. So it peaked earlier and it peaked higher, but is moving towards a more typical progression. And I can say, I'll show some later slides for our current season for 2024-25, and we are peaking in January. So we have now returned to that typical seasonal pattern. So with RSV, it usually becomes a common name around October to about February or March. And we'll talk a little bit about why it's really important to understand when RSV season occurs. Now, who gets RSV? We talked about those that are very young and those that are very old, but even in those age groups, there are particular individuals that are at more risk. So, of course, infants, young children, the younger you are, the more risk you have. Those that are American Indian or Alaskan Native children, children that are born prematurely, children with chronic lung disease or congenital heart disease. And so chronic lung disease can be something as simple as asthma. Kids that have asthma are more likely to have RSV or severe RSV infection. And then congenital heart disease are those that have heart issues at birth. Children with weakened immune systems, so those can be kids that are fighting cancer, undergoing chemotherapy. Children with cystic fibrosis, which is somewhat of a lung condition. And then those that have any neuromuscular disorders, meaning they have difficulty swallowing or handling their secretions and mucus. And as you remember, when we first talked about RSV, it causes a lot of mucus in those lower airways. So if you're having problems clearing all of that, then this can be a severe illness for you. Now, let's talk about disparities. Disparities do exist like most things in healthcare. With RSV, we know that there are disparities in the Black community. You have higher rates of hospitalization. There's higher ICU admissions, and those are the ones that require very one-to-one care with the nurse or that have more severe cases. And then there's unequal access to RSV prevention by immunization. So RSV can be prevented with immunization through mom or baby, FQACs and access to vaccines. So I'll give you an example. Um, there's an FQAC that I know of that will treat pregnant mothers and treat children. And frequently, what we will see is that the moms will come in with their baby, and the mom doesn't know anything about the RSV vaccine. This vaccine has been approved since 2023, and you would think that the gynecologist or obstetrics doctor would be aware or would let them know. And of course, they are aware and they do let them know. But with this particular FQHC, they just don't have the vaccine. They just don't carry it. They can't give it to the moms. And so therefore the moms have to go their entire pregnancy without that vaccine just due to lack of access to it. And so of course that funnels down to care when it comes to the babies, as in they don't have the benefits of having a mom that was vaccinated against RSV. And that is not in the control of the parent at all. That is literally just access in the clinic that they chose to go to. Now, those that are lower socioeconomic status also have higher rates of hospitalization and tend to have more severe disease. Now, I spoke about the seasonal trends of RSV. And so these two graphs kind of highlight the difference between the Caucasian population and African American population when it comes to peaks during the RSV season and decline. So if you look at the chart on the left, that is our Caucasian children, 1 to 7. It peaked at around early January at about 8.5 children per 100,000 hospitalizations. So these are kids that are hospitalized with RSV. And then when you look at the African American kids, it peaked at about 9.5 or so per 100,000. So it's definitely a higher peak, and it occurred just a little bit later. But you do see that African American children tend to be impacted a little bit more. I will say that there is a big trend going down when it comes to the cases, and I suspect that some of this has to do with there was a gap between the end of January until quite recently in reporting of RSV cases via the lab, based on the pause in communication with the CDC and the NIH. And so I suppose that that is some of the reason why there's such a sharp decline in the actual numbers that are reported. Now, this graph kind of goes over the vaccination rates. As in the case I stated earlier with FQHCs, which are federally qualified health centers, let me just clarify. Federally qualified health centers tend to work with patients that are lower socioeconomic status or those that have Medicaid, meaning they're in a poverty status and they don't have private insurance. And so that is one of the reasons why you have a harder time getting the vaccines there. But based on our graph here, this is looking at vaccination rates in different populations. So our green line at the bottom looks at our African American percentage of pregnant women that are vaccinated. As you see, it peaks probably around 25% around the end of January, with 25% of African American pregnant women being vaccinated against RSV. When you look at the orange line, that's our white population, it peaks almost close to 40%. I would say 38, 39%. And it peaks pretty early and it stays there. So about 38, 39% of pregnant women who are Caucasian are getting the RSV vaccine. So that's a big gap in the percentage of uptake of that vaccine. And again, there are lots of reasons in the background as to why certain populations are not being vaccinated. Now, the teal line there is overall for all ethnicities. So as you can see, comparing the orange and teal to just the green line, there is a large disparity and a large gap in the percentage of African American women actually taking the RSV vaccine. Now, what can you do about RSV? Okay. Prevention is key. And so vaccination, we talked about it with the graph ensuring that moms can be vaccinated. That is the main way that you can prevent RSV in baby. This goes over a little bit about the different age groups and the vaccines or immunizations that are available. So if you are over 60 or an adult, there is an RSV vaccine. It is encouraged for everybody. We're here talking about babies, and ultimately, the RSV vaccine that we give mothers is to protect the baby. And then we give the baby RSV antibodies once they're born in order to protect them. Okay. So let's talk a little bit about the RSV vaccine for mothers. I cannot pronounce this, but it was approved back in May of 2023. It is recommended for all pregnant people that are 32 to 36 weeks between September to January. So if you remember our seasonal pattern, that is right in the RSV season. So we want to make sure that mom has the vaccine, and then therefore the baby has the antibodies. So a little bit about how vaccines work is that when the person takes the vaccine, it stimulates their immune system to produce antibodies. And what the antibodies do is ready themselves, as in if your body is exposed to a particular bacteria or virus or whatever it is that you got a vaccine for, your antibodies will fight it off almost immediately and say, hey, we're going to get this out of our system. We're going to kill it. We're not going to be totally infected by this. And so you give the vaccine to the moms when she's at the end of her pregnancy so that she can make those antibodies. And when the baby's born, the baby's blood carries those antibodies. And even more, if the mother is breastfeeding, she's now transferring those antibodies through her breast milk to the baby. And those antibodies come from the mom, but they protect the baby. Now, for the baby, Beyfortus, I know how to pronounce that one, is the antibody that we give babies. There are two injections based on the age, based on the size of the child. And so there's a little mistake here. I put the wrong information for Beyfortus, but Beyfortus is an injection that's given to babies within the first couple of months of life, depending on their risk profile. And so you give the injection within a week of birth. And this is all if mom has not gotten the vaccine. If mom has gotten the RSV vaccine, baby does not need Beyfortus at all. But if the mom has not gotten Beyfortus, if the mom has not gotten the RSV vaccine, then you give the baby Beyfortus. And so you give it to her within a week of life. One injection will protect the baby for up to 5 months throughout the RSV season. And so you typically give it between October all the way till March, depending on when the baby's born. And in high risk babies, as we talked about, those that have chronic lung disease, um, those that have heart conditions, you can give it all the way up until they're 2 years old. Okay. And this is an immediate protection. As the top line says, it's 90% effective in preventing babies from being hospitalized. So disregard all the rest in the middle that is left over from a previous slide. Now, what else can you do outside of vaccines and immunization and antibodies? Behavioral strategies. And so the chart that we looked at that had, or the graph we looked at that had the seasonal trends, and it showed that in 2020, it was a flat line. In 2021, it was a small peak. A lot of that had to do with these behavior strategies and parents and children observing these so that you decrease the transmission of respiratory viruses, including RSV. So that's good hand hygiene, washing your hands, covering your cough or sneeze, using a mask when you're sick, as well as sanitizing, and then cleaning frequently touched surfaces, as well as staying away from others when you're sick or, not being around anyone. Now, there is a fact that sometimes makes parents uncomfortable is that nearly every child will get RSV by the time they're two. And if you looked at my other slide, it said 2 out of 3 children will get RSV by the time they're one. So this is a very common illness. And the important part is that some people will get very sick, and that's why we need to identify who's going to be those that get really sick. But when you do, and if you do get RSV, what do you do? So first of all, there is no cure. There's absolutely no cure to get rid of it. We don't have any antiviral medications that we recommend. Typically, RSV, like I said, has a typical progression and it tends to resolve on its own. But the things you can do at home to relieve symptoms, suction out the nose. Babies are what we call obligate nose breathers. So what that means is they use their nose and their nose only to breathe. Unless it's obstructed, then they have to breathe through their mouth. And so the cleaner that the nose is, the less mucus there is, the easier it is there to breathe. Humidifier in the room, that's going to help moisturize the air to manage the secretions. so that it's looser and they can actually breathe through it. Manage any fevers, Tylenol or ibuprofen, depending on your child's age. Make sure they're drinking enough fluids and not getting dehydrated, okay? And then, of course, if there's anything that comes up that you're concerned about, talk to your doctor. Now, a few takeaways from our talk today. Black communities tend to have more severe disease. There's higher hospitalization rates, and even lower access to preventative care. But what can we do? So, knowledge is power. We need to make sure we educate ourselves so that we know exactly what to do. Know what RSV is. And as we discussed, RSV is a virus. It is very common. Most kids will get this. It usually causes lots of mucus and secretions, and that's how we get a lot of the symptoms, the coughing that kids have. It is seasonal, meaning you can predict that around October to March or so, somebody's going to get RSV. And so you can definitely utilize your strategies to know how to maneuver during the season. Know your risk level for severe infection. So that means if you have asthma, if your child has asthma, if your child has a heart condition, if your child was premature, you definitely need to be on the lookout for RSV. And of course, if your baby is recently born within a few months of life, you should talk to your pediatrician or your provider about making sure your child is vaccinated against RSV. That is, if you have not been vaccinated. And then know what to look for, the signs and symptoms. I showed a video with the baby that was coughing, had a lot of mucus, the rib pulling, the tracheal pulling. Those are things that you want to look for. And even decrease eating to see if you suspect that your child has RSV. And then how to manage the illness. And so we talked about making sure we suction out the nose, we use a humidifier in the room. Those are all things that are going to be helpful with managing it. Now, one thing I forgot to talk about is how we diagnose RSV. And so when it comes to RSV, if you see signs or symptoms, definitely talk with your pediatrician. Go into the office. There's a swab that can be done from the nose, and that sample can be sent to the lab. That's how we get all of our stats and all of our statistics is from the lab, but that can be sent to the lab and they can detect the RSV. And if it comes back positive, we let you know. Now, the other thing is prevention, okay? Prevention is key. You want to utilize your behavioral strategies. Like I said, make sure nobody's kissing your tiny baby. Wash your hands frequently, use a mask, stay home when you're sick. Those are all helpful things. And then think about immunization. RSV vaccines for mom between the 32nd to the 36th week, and antibody Beyfortus for baby if mom wasn't vaccinated. So I want to leave you guys with this video. It's gonna talk a little bit about what we discussed, hit the high points, and kind of bring home why RSV is important and why we need to talk about it as a community.
Welcoming a new baby to the family is an exciting time, and expectant parents have many questions. Now, you can help protect your baby against RSV, Respiratory Syncytial Virus. RSV is a common respiratory virus that causes symptoms like the common cold, but for some, including babies, it can become severe and even life-threatening. RSV can cause difficulty breathing, low oxygen levels, and dehydration in infants. It's the leading cause of inflammation of the small airways in the lungs and pneumonia in babies younger than 1. RSV is also the leading cause of hospitalization among infants. A new preventive antibody is recommended for babies younger than 8 months old, shortly before or during RSV season. Our bodies naturally make antibodies to help defend against harmful substances like viruses, including RSV. A baby's immune system isn't fully developed, so they need a little extra help. A preventive antibody copies what a natural antibody does, providing a boost to the immune system and protection against disease. Although this preventive antibody is given through an injection, it is not a vaccine. It does not stimulate the body's immune system like a vaccine does, and it starts working right away. Ideally, newborn babies should receive it within a week of birth during RSV season, or beginning in October for babies born earlier. One dose lasts at least 5 months. Talk to your healthcare provider regarding any questions and learn more at lung.org/RSV.
All right. So thank you so much for engaging in this conversation about RSV and why it's important in our communities. Any questions?
Thank you, Dr. Wanda, for this wonderful presentation. There are some questions in the Q&A. Some of them you have answered, but I'll just read them all and you can restate it, go back to the slide and kind of refresh everyone's memory with that. So the first question is, how can community health initiatives be tailored to effectively address RSV prevention and management?
Yes. So community health, did you say community health interventions?
Initiatives. So yes, that would
Community
also
health
include
initiatives.
intervention.
Yes. So community health initiatives. So that usually would be in kind of like a FQHC, like I discussed with the federally qualified health center. They typically are the centers that are going out into the communities. And a lot of it would be just awareness of the vaccines that are available for moms, and if not moms, then the antibodies that are available for babies. So a lot of it is education, understanding how you prevent RSV with those vaccines, as well as I think we all understand the behavioral strategies at this point after going through a pandemic. And then just kind of understanding that you do have to look for it, you have to be aware of it, and you have to actually get treatment. So, understanding the seasonal variability of it, as well as the symptoms and what to look for and where to go.
Thank you. Another one, I know it's recommended for moms to get this during weeks 32 through 36. Do you show that it's effective once babies are born?
Yes. So when you say, do you show that it's effective or can I show that it's effective? Um, I will have to look at the rates of RSV in babies that have been maternally vaccinated. Okay. I think it kind of gets a little hazy because the way the vaccine works maternally is that in all vaccines in general is that it stimulates your body to produce antibodies. And what we already know is that mom's antibodies cross over to the baby, not only when the baby is in the mom's body, but also through the breast milk. And the babies continue to carry those antibodies for up to 6 months after the baby is born. So, as long as the mom is vaccinated, then the baby carries all the antibodies for the mom. And this has been proven in other studies with other vaccines. Mom gets Tdap through every pregnancy to protect the baby against uh, diphtheria, tetanus, and pertussis when the baby comes out. And so we already know that that works. The RSV vaccine works. And then we all know that breast milk carries antibodies that babies tend to take in as well. So,
Thank you. Another question, how do social determinants of health and access to healthcare influence RSV outcomes?
oh yes. So that is a really good question. So access to care and how that influences RSV outcomes. Now, I'll give you an example. Say, for instance, you're a mom, you got 5 kids, you got to be at work tonight, and your youngest is only 4 months, right? And your oldest kid is watching your youngest kid. They end up having a cough or a cold, and it's been going on for a few days. But tonight things kind of got worse. Are you gonna go to work? Are you gonna take your baby to the hospital? Are you gonna, are you gonna what are you going to do? So sometimes in those situations, it can be a very tough decision as to, you know, what you do and how you care. So sometimes there can be a delay in care if you got to maneuver things around. And we tend to see that in those that have lower socioeconomic status, those that have a little bit more demands on their time. And so, if, say, for instance, we know our predictable pattern is 1 to 3 days, you're not really severe, 3 to 5, things kind of peak. 5 to 10, things kind of get better. You have a baby that was in the NICU and was born very early, and you see that they have a cough or a cold, and it's been the first day, and the second day it gets worse. Take the baby into the office, and they get tested. You find out it's RSV. I've had babies that come in every day so we can watch them and see how things are going. But if you just don't have the time, if you just don't have the ability to get to clinic every day, then that can end with you presenting to the emergency room on day 5 because you didn't know what else to do. And so that by itself can change the outcome.
Thank you. Another question, are the vaccines offered at the time of birth?
That is a great question. So it depends on the hospital. So the vaccine is for moms. The benefit to the baby only occurs if the vaccine is given before the baby's born. So you can't get the, what is it, Abrizio, I think, I don't know what the name is, but you can't get that vaccine as a pregnant mother on the day you deliver a baby because it has no benefit. Now, once the baby is born, yes, you can get the RSV vaccine. I have seen the RSV antibody. I am commingling. The vaccine is for the mom, the antibody is for the baby. The baby can get the RSV antibody, yes, as soon as they're born, before they even leave the hospital to get them protected. And that's typical practice when a baby is born in the thick of RSV season.
Okay, thank you.
Yes.
Another question, how does RSV impact infants differently compared to other school-age children? What are the implications for treatment?
Yes. So, how does it impact younger children versus older children? And what are the implications for treatment? So I'll just start with treatment. Treatment in general is supportive. And so what that means is there is no cure for RSV. We manage it by managing all the symptoms that come from the illness. So if the baby is coughing, breathing fast, having a hard time breathing, we may give them a breathing treatment to help kind of open up the airways so they can breathe better. If the baby has a lot of mucus, we may end up suctioning their nose and down their throat to kind of get some of the mucus out. If the baby has a fever, we give them Tylenol. So the mainstay of treatment, whether it's a newborn or an older kid, is just supportive in managing the symptoms. Now, how does it impact younger versus older kids? Um, like one of my slides said, most kids will get RSV by the time they're 3. So if you get RSV as a school-age child, chances are you will be perfectly fine. That is unless you are one of those children that either have chronic lung disease like asthma, a heart condition, problems handling your secretions, or chronic pneumonias, then you are at risk. As to your progression and to how the illness will progress, it really just depends on your illness, your underlying illness. Now, newborns in general, whether they have a chronic lung disease, a heart condition, or anything, they tend to fare worse than older children, even the healthier ones. And so, with that, it's pretty much based on age. So, the younger you are, the worse the outcome may be if you get a severe case.
Thank you.
Yes.
Another question. I don't feel like the RSV vaccine is pushed enough. Why isn't it offered during the flu season?
So that's wonderful. So I think it really just depends on the practitioner and who you're seeing. So again, with RSV, the vaccine, we're talking about pregnant moms. And again, it has to do with the education of your provider. This is a very new vaccine that was approved in May of 2023. It may not seem new to you, but in the grand scheme of medicine, it is very new. And so some providers may not be aware of it if they aren't staying up to date on all of the recommendations. And then some providers may not have access to it. Some hospitals may not actually have the vaccine to give. And so therefore they're not talking about it. Um, it is a new concept to obstetricians to talk about RSV. I'll say that. As a pediatrician, it has been the mainstay of our education, and what we do is treating RSV and preventing RSV. But this is a new front for obstetrics. They don't usually talk about RSV. So I think that may also be a barrier in why OB/GYN doctors are not pushing the vaccine as much. So those are the three things for that. Now, when it comes to the RSV antibody that we give babies, that has been around for a very long time. Um, what has changed is the recommendation. So, a few years back, when I finished residency, we had the RSV vaccine and we only gave it to children that were high risk. Like I said, chronic lung disease, heart conditions, couldn't handle their secretions, things like that. But over the past, maybe I say year to 2 years, the new vaccine schedules came out and it recommended the RSV vaccine for every newborn and every child. And so now we've gotten away from just giving, I'm sorry, not the vaccine, the antibodies. We've gotten away from just giving the antibodies to those that are high risk and giving that to everybody because of the risk of RSV in a newborn. So if you're seeing a pediatrician, they should be pushing that RSV antibodies for your child, or at least asking you to get vaccinated. And then there are levels to knowledge with pediatricians as well, or with providers. And so some babies are being cared for by pediatricians who are specialized MDs or DOs that treat babies and children. Some kids are being cared for by nurse practitioners, and some children are being cared for by family medicine docs. And there are all levels in what we know and what we are comfortable with explaining to our patients. So I think all of that kind of explains why the RSV vaccine is not being pushed as much as it should. But as a pediatrician, we really do value having the ability to help prevent RSV infection because we hate to see the hospital. We hate to see babies like the one I showed you in the video. Thank
Thank you. There are a lot of questions, so this is good.
you. Mhm.
What are some cultural slash home remedies used by mothers and grandmothers in our community that you encourage, and then others that you may discourage regarding RSV treatment?
So, okay, so when it comes to RSV treatment and home remedies, um, there are a few things I encourage, few things I discourage. So there are lots of over-the-counter, all natural cough syrups that you can give babies. Some of them are okay, some of them are not. If your baby is under the age of 1, you shouldn't be using anything with honey. And a lot of cough medicines have honey in them. The reason is because honey carries botulinum toxin, which is a disease that can make babies very sick. So that is why we do not give anything with honey to babies under the age of 1. So I don't encourage that. Now, there are all natural cough syrups that have agave syrup, which is like a thickener that coats the throat so that it's not as irritating for the babies and they don't want to cough as much. That's fine. Do I think it's gonna cure or really treat well? Not really. There are other remedies that parents will do where they put Vicks on the chest. They'll put, I think, onions in the socks. I think put Vicks on the feet. That as well. All of those things are fine. I don't think any of that is going to harm your child. Do I think it's going to work? Mm, I don't think so, but I don't see any harm in parents doing that with their child. Um, but yeah, I mean, other than the typical remedies, which would be making sure you clear the nose out, suction the nose, especially before feeding and before going to bed, so that the baby can breathe well. Um, Humidifier, moisturizing the air, making sure the baby's drinking. Those are the mainstay of supportive management for RSV.
Thank you. Another question. How would you suggest you speak to parents who are anti-vaccine?
Mhm. So as a pediatrician, I see this quite often, and I have quite a few patients that are anti-vaccine, as you say. I always state that I have never seen an anti-vaccine patient or parent that did not love their child. So I think you first have to approach it with understanding that the parent is ultimately wanting to do what's best for the child. Even if, in my clinical judgment, I think that is very um, not the way to go. But I know that they're doing it out of love. So when you approach it that way, then you can take the time to listen. And so I always listen. What is the reason that you decided you don't want to do vaccines? And based on how is there anything I can do or say that might make you consider it? And if they tell me no, there's nothing you can say or anything you can do, then I say, hey, well, this is what I do. So I will have this discussion with you every day, kind of jokingly, or every time you come in, kind of jokingly, just to kind of break the ice a little bit. But I continue to try to keep a rapport with the parent and try to make them feel comfortable. Of course, doing my job, making sure they sign the paperwork saying they don't want the vaccines and making sure I document that I gave them everything I needed to give them. But the relationship between you and the parent are utmost when it comes to taking care of a child because you're fortunately going to be that child's doctor for 18 years and you're going to be in communication with those parents. And so what you don't want to do is break that bond or that communication. So even if they don't vaccinate, even if they don't agree with everything you're saying, I've had parents come in and I saw them 3 times and I said, listen, we're going to talk about this vaccine again. Okay. I know you don't want to hear it, but let me tell you this. And then oh my goodness. Okay. So I looked some stuff up. Maybe we'll do one today. We'll do one vaccine. And sometimes they actually give in if you just continue to approach them with compassion and know that everything that they're doing out of love and you just continue to talk to them.
Thank you. Another question. Maybe this was addressed already. What are the distinguishing differences between RSV symptoms and an asthma attack? Are these commonly confused by parents?
Yes, absolutely. That is a really, really good question. And so, first, I'll start with the diagnosis of asthma. Asthma is a hard diagnosis to make in a child under 3. I typically don't make that diagnosis. What I will say is you have reactive airway disease. Reactive airway disease means that your airways get smaller on their own or through some type of trigger, whether that is a illness, a virus, RSV. They get smaller and then they open back up when they get albuterol. They get smaller. They open up when they get albuterol. That is what we call reactive airway disease. That is the basis for asthma. What asthma is you get a trigger, it clamps down your airways, it opens up. It isn't until a child is after 3 years old, after they've proven to us that albuterol will do that, then we say, boom, you got asthma. Most kids under the age of 3 will have wheezing, meaning their airways will get small enough that they're whistling air. That's what wheezing is. That airway smallness can be either through RSV in the mucus or because the kid is gonna have asthma in the future. Okay. So when children are under the age of 3, you really can't call it asthma. And this is me speaking as a pediatrician. Like I said, kids are being cared for by nurse practitioners, by family nurse practitioners, by family medicine docs. And a lot of us have different practices, and this is my practice. But I don't diagnose kids with asthma under the age of 3 because all kids will have reactive airway from some type of illness. And it isn't until they've proven to us over and over again that we say, oh, this is asthma.
Thank you. That's good to know. Um, what are some common myths about RSV that you believe need to be dispelled in the Black community?
That's a good question. RSV myths, that it's a touch of asthma. So that one I hear often, right? So your baby gets sick. Maybe they got admitted because they were wheezing and it was turned out to be RSV. And now the baby comes into my clinic and dad says, oh, my baby got a touch of asthma because they were wheezing in the hospital and they got admitted. No, no. Your baby can wheeze with RSV just by virtue of their airways got smaller because of all the mucus. We cannot call it asthma until we've proven that that is the case. And in my case, that they're over the age of 3. So yeah, that's a big one. It's a touch of asthma. Um, yeah, that's the main one.
Okay, we got 2 more. How can pediatric healthcare providers better educate parents about RSV prevention and care?
It starts with maternity. It starts with the obstetrics and gynecologists, working with them and just trying to get the knowledge to them. Like I said, it is RSV is a new concept for obstetricians to even talk about. And so as a pediatrician, I think we have to do better at educating them on how to educate the parents. Because each mother that gets this vaccine before they deliver makes life easier for their baby. And me as a pediatrician, with less rates of RSV admission, less rates of severe cases. If those babies come out of the womb with antibodies already primed and ready, so that if they see RSV, they're not going to get severely sick, that's what we want. So I think the biggest thing is education to our obstetricians and gynecologists with, a collaborative effort to keep all the babies safe and healthy.
Thank you. And our last question, what do you think about the usage of elderberry?
So elderberry, yes, it has been proven to help with boosting your immune system. Do I think it's going to cure anything? No. I do not think that elderberry is going to cure anything. If you use it as a preventative measure, meaning, oh, I do this regularly just to make sure my immune system is nice and primed in case I get sick, I think that's perfectly fine. Of course, elderberries can be unsafe for children if they're consumed because they are poisonous by themselves, like without boiled or anything. So you definitely want to be wary of that around children if you just have raw elderberry. But nonetheless, you can use it for preventative purposes. But once you get sick, I'm not sure that elderberry is going to cure your illness. Now, it may help your immune system, but I think that some people think that using elderberry can be a substitute for traditional medications and cures, which I think is a mistake. So, preventative, I think it's a good use.
Thank you. I just wanted to take the opportunity again to thank you for taking the time this evening to talk to our families about our African American babies and RSV and making sure that we're doing what we can to help drop those rates to make sure our babies are healthy and getting the care that they need. So I really do appreciate this.
You're welcome.